Harry Vinters, and I'm one of the neuropathologists here. This is a talk that was bumped from a previous session on neuropathologic substrates of epilepsy, which is one of my favorite topics because actually we see a tremendous amount of tissue from epilepsy surgeries here, and the pathology of it is really very unique and rather heterogeneous, although there are certain patterns of pathology that we see, especially in children, and then other patterns that we see in adults. So I'll go through that because it's a favorite thing to put on the boards, the neurosurgery boards, and certainly the neuropathology boards as well. One of the areas that I'll show you and that I'll be talking about will be cortical dysplasia and tuberous sclerosis. And those areas are actually very hot in the area of molecular neurobiology as well, because there are now some very interesting models of tuberous sclerosis based on knocking out and selectively expressing different genes that lead to a really high-fidelity model of tuberous sclerosis in mice. And that's been quite an accomplishment because people have been trying to develop that for about 15 years, 10 or 15 years. And there's now a model that's about to be published in the PNAS in the next few weeks that is really pretty dramatic. We were involved with some of the pathology on that, so it's really an incredible model. As you know, epilepsy surgery was really kind of pioneered. It's generally attributed to being started by Wilder Penfield in Canada. Wilder Penfield was the founder and the first director of the Montreal Neurologic Institute in Montreal. Has anyone been there actually to the MNI? It's an amazing place. And even though he was American, he moved to Canada and really spent his entire career in Canada. And really pioneered epilepsy surgery. And what was interesting about Wilder Penfield was that he developed and put together an incredibly good team at the Montreal Neurologic Institute to study the pathology, the pathogenesis of epilepsy, and to refine surgical techniques. And Wilder Penfield himself, who died about 30 or 35 years ago, was actually an extremely good neuropathologist himself. Not only was he a great neurosurgeon, but he was a very, very good neuropathologist and pioneered a lot of the observations on epileptogenic tissue. He had an amazing ability also to gain political power and to get money from the government, and to also assemble a team that would really be very good at looking at the patients and the tissue. So, for example, he got the services of Brenda Milner, who was one of the founders of neuropsychology, and the neuropathologist who actually looked at a lot of the early material is Gordon Matheson, who's now retired, but he's in his 80s now, but he's still around, and really looked at and published some of the early papers on what he was seeing in the epilepsy tissue. And it was all very novel at the time, and to the point where he really had to make up some of the terminology to describe the lesions. We're beyond that point now, and we have certain patterns of pathology, and I'll show you those patterns. This is an appearance familiar to all of you. This is from one of Gary Mathern's surgeries, the picture that he lent me. Someone who's about to probably have a hemispherectomy or at least a multilobar resection for probably cortical dysplasia. I'm just guessing that from the abnormal gyral pattern here, and I'll show you what the microscopic features of cortical dysplasia look like. And we have one of the largest collections of cortical dysplasia cases in the world here, including hemimegalencephaly and multilobar cortical dysplasia and so on. And this is just kind of an intro slide to show you a case of severe cortical dysplasia. Not that that's the only thing I'm going to discuss, but it shows you a relatively normal cortical ribbon and then large collections of heterotopic gray matter in the deep subcortical white matter, which is characteristic of some of the types of cortical dysplasia that we encounter. So this is from one of the cortical dysplasia surgeries. It might actually have been a hemimegalencephaly. Epilepsy surgery, some of the best papers and review articles on the workup of patients who eventually have epilepsy surgery, of course, have originated from UCLA. Paul Crandall, who retired from here in the late 1980s, worked with Pete Engel, who's still very much around, as I'm sure you know. And this is from a review article that's now kind of ancient history. It's about 14, 15 years old. But Pete wrote a very nice New England Journal review article summarizing the importance of epilepsy surgery for the evolution of the field in the mid-1990s. When he wrote this article, the most common surgical procedure, of course, was temporal lobectomy or amygdalohippocampectomy. It was far and away the most common neurosurgical procedure, and it may still be. I haven't seen updated figures, although I'm sure Pete has them. And neocortical resections were relatively much less commonly done, only about 1/5 as many as temporal lobectomies and amygdalohippocampectomies. And then there were lesionectomies, which were just removal of an epileptogenic lesion. Hemispherectomies were still relatively uncommon at the time Pete wrote this article, although they were coming back into use. And callosotomy, which is a procedure that we as neuropathologists don't like because it doesn't result in any tissue, obviously. But now I think the pendulum has swung, and I think there are now a lot more neocortical resections, although temporal lobectomy is extremely important in treating intractable temporal lobe seizures. Dr. Engel makes the extremely important point that probably only a tiny fraction of the people in the world who would benefit from temporal lobectomy or amygdalo-hippocampectomy actually have the procedure. Because of government resources or medical resources, it's simply not available to thousands or tens of thousands of people who would benefit from the surgical procedure. So it's done a lot in North America and in Europe, but much less commonly in developing countries. And to Dr. Engel's credit, he's been one of the people who's gone around the world to try to popularize the procedure. And there are now significant lobectomy programs in India and many third world countries as well. Although resource challenges there are many people who are not operated on who would benefit from the surgery. And this is just kind of a boilerplate slide to remind you that the surgeries, of course, are never entered into in a cavalier fashion, that patients are worked up using very extensive multimodality imaging techniques, electroencephalography. They have trials of medication and so on, and surgery is really only done as a last resort, although sometimes it's done quite early, as you know, because of in the case of infants with cortical dysplasia or infantile spasms, they of course are seizing literally from the time they are born. And the surgery has to be done quite early. And this just shows a number of different lesions: a hippocampal lesion, a discrete neocortical lesion, possibly a tumor, and then a diffuse hemispheric abnormality involving the entire left cerebral hemisphere in a case of hemiamegalencephaly. And we have one of the largest collections of hemiamegalencephaly cases in the world as well. So it's a huge treasure trove of material to study here. So my goals in the next 40 minutes or so will be to talk about the spectrum of structural brain lesions associated with intractable epilepsy, talk about optimal tissue handling, and I'll talk about the gross and microscopic features of selected lesions, cortical dysplasia in pediatric epilepsy, which is a very large growth industry, the pathologic grading or staging of cortical dysplasia, because there's been a new grading scheme that was that's just been released, just published a few months ago in Epilepsia. Then the relationship between cortical dysplasia and tuberous sclerosis complex. And then finally, we'll talk about Rasmussen encephalitis, which is much less common than cortical dysplasia, but is a very mysterious inflammatory disorder that is very interesting and biologically interesting, despite its rarity. So this is a summary of the structural lesions associated with epilepsy. I'm not going to talk about all of these lesions. I'm going to spend most of my time talking about parenchymal abnormalities, including cortical dysplasia. I'm not going to talk about vascular lesions. Again, as I mentioned, I'll talk a little bit about the relationship between cortical dysplasia and tuberous sclerosis. I'll just show you an example of Sturge-Weber-Dimitri syndrome or encephalotrigeminal angiomatosis, because they like to put that on the boards. I'll show you some perinatal ischemic lesions that cause epilepsy, although, of course, ischemic lesions at any age, stroke, can be associated with intractable seizures. And the only real inflammatory disorder I'll talk about, if I have time, is going to be Rasmussen or pathogen-free encephalitis. I say pathogen-free because we don't know of a pathogen yet in that disorder. None has been discovered yet, but we're looking for one. This is going back again to one of Gordon Matheson's papers, published in 1975, and he published the Montreal Neurologic Institute experience between 1960 and 1970, a total of over 500 cases, which is a pretty impressive number for that era, considering that CT scanning was about 6 or 7 years away from being developed, and MRI scanning was a lot longer away. So it was pretty gutsy of the surgeons to go ahead and do surgeries based on EEG, which was relatively primitive at the time, and I'm not even sure that anything resembling electrocorticography. This summarizes the spectrum of abnormalities that he encountered. Of course, a significant number of the cases were gliomas, and I'm not really going to talk about epileptogenic tumors today. I have a whole separate lecture on pediatric brain tumors, including tumors that cause epilepsy, and I can give that at another time. But this is what I mean by the fact that it was really difficult to give the names to many of the lesions that he encountered. This simply refers to a meningocortical scar, presumably on the basis of ischemic disease, residuum of a cerebral abscess or pyogenic meningitis, which was a common indication for surgery. But then there were very nonspecific abnormalities, things like cortical neuron loss and gliosis. And hippocampal sclerosis was being recognized at the time, and it was a relatively common cause of intractable epilepsy in the MNI collection. And there were only minor abnormalities in about 1 out of every 1 out of every 5, 1 out of every 6 cases. So you could look microscopically for abnormalities, but you weren't able to find anything. Again, it's important to remember that this paper came out long before the days of immunohistochemistry, and of course that's changed now. We can actually recognize things that are not really apparent on light microscopy. The lesion that we now call cortical dysplasia, he called tuberous sclerosis and forme fruste of tuberous sclerosis. The reason being that cortical dysplasia looks very much like tuberous sclerosis, at least in its most severe forms. So kind of an interesting historical paper, and shows how different our appreciation is of epileptogenic lesions now. A couple of words about optimal handling of tissue from the epilepsy operating room, which I'm sure you're familiar with. And that is that portions of the material, of course, are given to either Itzhak Fried's lab or Carlos Cepeda's lab because they need it for electrophysiological studies. And actually, Jay was involved. He got his PhD working with that group. We actually do a number of things on the tissue as well, although we don't necessarily do all of these immunohistochemical procedures on every case. But the Kluver-Barrera stain, of which I'll show you an example, is very good for showing subtle degrees of cortical dysplasia. GFAP immunohistochemistry is valuable for assessing patterns of astrocytic gliosis or scarring, which occur with almost all types of destructive brain lesions, and there are also significant amounts of gliosis, namely proliferation of GFAP-positive astrocytes in cortical dysplasia as well. Increasingly, we use microglial markers, including HAM56, CD68, and a new one that we use more commonly in Rasmussen encephalitis called IBA1 to characterize microglial proliferation, which is really a hallmark of Rasmussen encephalitis, although there is some degree of microglial activation also in other types of epilepsy lesions. We do T and B cell markers if we're dealing with a case of Rasmussen encephalitis, cytoskeletal markers, and synaptophysin. And now, of course, we have antibodies to the proteins that are known to be important in things like tuberous sclerosis, and those two important proteins are Hamertin, encoded by the TSC1 gene on chromosome 9, and tuberin, which is the TSC2 gene product on chromosome 16. Both of those were found in the 1990s. So we want to give you a good pathologic diagnosis. What is the lesion? What caused the lesion? And for that, we can use immunohistochemistry in situ hybridization. In the case of Rasmussen, we've tried viral culture or PCR analyses, but those have been fairly non-productive. They've shown results, but really nothing specific. And Carol Cruz here actually works in the brain tumor program, has just gotten a grant here to study, look for possible novel causal agents in Rasmussen encephalitis. And then how was the lesion producing the seizures? And this is where the neurophysiological component of the studies becomes extremely important. And this is the kind of work that I think Jay Hauptman has been doing for the last year. So the tissue goes directly to the electrophysiology laboratories where they do spike recordings. And then after they've done their spike recordings, they inject the neuron with the neuron from which they've been recording with biocytin. You can actually see the cytoskeletal abnormalities and the cytologic abnormalities in the neuron that was being recorded from. It's a very powerful technology. Unfortunately, they can only record from a relatively small number of neurons in the course of a 12 or 13-hour recording session. So the N is fairly small, but the results are quite interesting, certainly with the database that they've built up. Some gross and microscopic features of selected lesions that cause epilepsy. This is actually from one of Gary's review articles, showing that when you operate on children under 18 years of age, of course, by far the most common neuropathologic substrate is cortical dysplasia. Neoplasms are a fairly distant second. Sequelae of ischemic lesions or strokes are a third, and then hippocampal sclerosis is relatively uncommon. in infants and children. However, when you're looking at individuals over 18 years of age, hippocampal sclerosis becomes the dominant pathology, and I'll show you an example of that. Tumors are a fairly close second, as opposed to being a distant second, but we still see examples of cortical dysplasia in adults, although not as commonly as in infants and children. And then vascular abnormalities, things like cavernomas, cavernous hemangiomas, or arteriovenous malformations are not uncommon. Especially cavernous hemangiomas tend to be epileptogenic. And when you look at a cavernous hemangioma, it kind of makes sense why that is, because there's a huge amount of destruction of the tissue and a lot of hemorrhage and gliosis in the surrounding brain parenchyma, often quite a bit more than there is around an arteriovenous malformation. So it's not surprising that they are epileptogenic. Just an example of cortical dysplasia. First of all, example of a normal hippocampus. And then to show you hippocampal sclerosis, this is the surgeon's eye view of the hippocampus. This is a picture lent to me by Gary, or given to me by Gary Mathern. And a reminder that the hippocampus is composed of the granule cell layer and then the pyramidal cell layer curving out of it. And you know that all of the segments of the pyramidal cell layer have names given to them. And hippocampal sclerosis basically consists of a selective loss of neurons in the CA1 zone with relative preservation of neurons in the CA2 zone and the subiculum. And the granule cell layer here is a very tight, compact neuronal layer. And what happens in hippocampal sclerosis is not only is there loss of neurons in CA1, but there also is kind of a reorganization in the granule cell layer, leading to what we describe as granule cell dispersion, which was an effect that was actually discovered here in the 1990s by Carolyn Hauser in the Department of Neurobiology. Not only is there loss of neurons in the CA1, but there's very often loss of neurons in the end plate region as well, and some people describe this as end folial sclerosis. Hippocampal sclerosis is, of course, important in epilepsy, in intractable temporal lobe epilepsy. It's also recognized now as being an important substrate of cognitive impairment and memory disturbance in the very elderly. People in their mid to late 80s and early 90s. It's now found that in very careful autopsy studies, when you look at the hippocampus, in fact, what they have is they might have some degree of Alzheimerization of the brain, but they very often have ischemic lesions in the hippocampus as well, with virtually the identical pattern of neuron loss and gliosis that we see in hippocampal sclerosis specimens from temporal lobe surgeries. And this is what the hippocampus looks like in somebody with hippocampal sclerosis. So there is some loss of neurons in the end folial region, so there's a degree of end folial sclerosis. But notice that the neurons in the subiculum and the CA2 zone are really remarkably well preserved. But the CA1 zone, or summer sector, is about 90 to 95% depleted of neurons. And if you did a stain for astrocytes here, you'd see a tremendous degree of astrocytic gliosis. So this is a classic example of hippocampal sclerosis. There's maybe a very subtle degree of granule cell dispersion here, but it's not as dramatic as we often see. And very often in temporal lobectomy specimens for intractable temporal lobe epilepsy, this is all we see. We don't see any other evidence of temporal lobe pathology, but increasingly, as people are starting to look at the extrahippocampal regions of the temporal lobe, we're finding abnormalities in those regions of the temporal lobe as well that are subtle, and there might be occasionally dual pathology. There might be a small neoplasm or tumorlet in the neocortex, temporal neocortex, and there may also be vascular malformation or evidence of even subtle cortical dysplasia. So this is classic hippocampal sclerosis. I'd love to put this on the boards. It's a very, very distinctive lesion histopathologically. The question is whether temporal lobe epilepsy actually in itself leads to progressive neuronal loss in the pyramidal cell layer of the hippocampus. And this is a very detailed study that from Gary Mathern about almost 9 years ago, where he actually looked at people who'd had temporal lobe epilepsy for various durations and found that, in fact, the number of neurons in the hippocampal pyramidal cell layer did decline, not precipitously, but slightly over the years, whereas in autopsy, age-matched autopsy specimens, there was no evidence of hippocampal neuron pyramidal cell loss over time. So this suggested that the seizures themselves actually do lead to progressive hippocampal pyramidal cell loss and injury. Suffice it to say that having temporal lobe epilepsy Another argument for surgery is that, in fact, there is worsening of the disease to some extent over time. So the bottom line is that hippocampal sclerosis is an acquired pathology rather than a congenital pathology. The most severe neuronal loss occurs with the IPI, or the initial precipitating incident, but there is progressive hippocampal damage from intractable temporal lobe epilepsy, regardless of pathology, though it may be fairly subtle. Just to turn to the pediatric age group, or to the age group that we see a large number of lesions from, to show you some of the types of pathology that we can see. This is an example of a destructive lesion that presumably represented an intrauterine or a perinatal infarct, and it really looks like it has the appearances of a cystic infarct that we would see in an adult. So here's a large area of cystic cavitation, very well demarcated from an otherwise normally formed cerebral cortex. And I don't remember the age of this child. I think the child was about 5 or 6 years of age. This infarct had been there a very long period of time, and what it is about the infarct that produces intractable seizures we don't know, except that at the interface between an infarct and brain there is a tremendous degree of astrocytic gliosis, and that scarring presumably could contribute to the intractable seizures. This is an example of Sturge-Weber disease, or encephalotrigeminal angiomatosis. This is actually a section of the occipital cortex. The pathology is very subtle, but if you look very closely in the cortex here, you can see sort of a punctate basophilic granulation, granularity, not granulation, which represents the calcification that you get in the superficial cortex. And if you actually did a soft tissue X-ray of this, you'd get the so-called tram track appearance of calcification in the superficial cortex. Sturge-Weber disease would be a very rare cause of epilepsy that we see in cortical resections. It would even be much less common than the numbers of Rasmussen encephalitis cases that we see from Dr. Mathern. But we do see about 1 or 2 cases of this every year. And this is associated with the port wine stain and so on and so forth. What's the genetics of, Rich, what's the genetics of Sturge-Weber disease? It's a trick question. It's one of the few neurocutaneous syndromes that is spontaneous, and there's no genetic basis for it, as opposed to TSC, neurofibromatosis, and so on. So Sturge-Weber disease is entirely sporadic. And there's a very nice monograph that somebody wrote on this a few years ago, which is still very valid, showing all of the clinical phenomena and the neuroimaging and the pathology as well. So, and it's been argued that in Sturge-Weber disease there is not only the vascular component, the meningeal angiomatosis, which I would agree is fairly subtle here, and the calcification in the cortex, but there's also an element of cortical dysplasia. And it's actually that malformative component in the cortex that leads to the seizures. But the general view has always been that the angiomatosis, the vascular abnormality in the meninges, actually leads to ischemic change in the underlying cortex, and that's what causes intractable seizures. All right, one of my favorite subjects, cortical dysplasia, but it's favorite for a reason because we see a large number of examples of this. And those of you who have rotated through neuropathology know that we also see the corticectomies for Miami Children's Hospital. So we have kind of a double dose of corticectomies here for epilepsy. And a lot of the Miami Children's Hospital cases are cortical dysplasia or tuberous sclerosis. So cortical dysplasia in pediatric epilepsy is a very interesting phenomenon. In that the first paper on this, as far as anyone can tell, was published by David Taylor in 1971, and David Taylor is still very much around, although he's retired now. After his brief flirtation with becoming an epileptologist, he became a psychiatrist and actually made very important contributions to understanding the psychiatric aspects of intractable epilepsy. He's a British fellow, and I met him at a meeting about 2 or 3 years ago, so hopefully he's still alive. And notice that the publications on cortical dysplasia were virtually non-existent. In 1971, David Taylor's was the only one. Then there were 2 or 3 papers in the 1970s, but for about 10 years there was really nothing written about cortical dysplasia until it was rediscovered in the 1980s. And now there's been, this only takes you up to 2007, but there now are easily 80 to 100 papers a year on various aspects of cortical dysplasia. And people are feverishly trying to make models of cortical dysplasia so they can study the neurobiology and the genetics of it more carefully. And they're looking for links between cortical dysplasia and tuberous sclerosis complex, which I'll show you. And this, again, is from an article that Gary's senior author on, review article. And it shows, as you might expect, that of course the most severe cases of cortical dysplasia are in infants. So when you look at the percent of individuals in the first 3 or 4 years of life, at least about half of those end up being cortical dysplasia, usually very severe cortical dysplasia. And the older the patient with epilepsy when they present, the less likely cortical dysplasia is to be an important or common neuropathologic substrate. So when you get into the late teen years, less than 10% of cases are caused by cortical dysplasia, but we sometimes see this even in people in their 20s and 30s and 40s. So it does exist, but it's much more common in infants and children with intractable epilepsy, usually with infantile spasms. And I'm not a neuroimaging person, obviously, but this, again, is from one of Gary's papers, showing that cortical dysplasia has various manifestations in terms of neuroimaging, and Noriko can tell you way more about this than I can, ranging from hemimegalencephaly, which is really the most severe example of cortical dysplasia, to what Gary calls hemispheric cortical dysplasia, in which there's not actually hemimegalencephaly, but there's very, very widespread multilobar, really cortical dysplasia affecting all lobes on MRI scanning, down to multilobar or lobar cortical dysplasia, and then the most subtle degree of cortical dysplasia, which is really focal cortical dysplasia, involving only a segment of one lobe. And this can be picked up by MRI scanning, certainly by Noriko, although what Noriko, as you know, very commonly does now is co-registration between MRI scanning and PET scanning, because the areas of cortical dysplasia tend to be hypometabolic. And these are actually 2 sets of images that she gave to me, showing again on structural imaging that the cortical dysplasia can really be quite subtle, but there definitely seems to be some widening of the cortex and maybe blurring of the cortex-white matter junction. And this is an example of a case of a 19-year-old, an older individual, where the structural imaging shows a very subtle lesion on MRI, but ECOG apparently showed a confluence of electrical abnormality overlying this area. So that, together with the subtle MRI abnormalities, pointed to this as an area of an area likely to be epileptogenic. So the image is extremely common. This shows one of the is extremely valuable. This shows co-registration between the neuroimaging MRI scanning, showing an abnormality, albeit fairly subtle, at least to me, in the right frontal lobe. And then it shows an area of hypometabolism on PET scanning. And this is a coronal view, I believe, from another patient, might be the same patient, showing hypometabolism and then, again, a structural abnormality on MRI scanning. And we have a number of projects with Noriko trying to characterize the neuropathology in these areas. So this is kind of a specimen of historical interest. This was the first hemispherectomy that Warwick Peacock did in 1986. And we received this specimen in surgical pathology. You can imagine how everyone in surgical pathology freaked out when they saw this, learning that it was a surgical specimen from a 3 or 3.5-year-old. And the abnormalities here are pretty subtle, right? I mean, you see a little bit of busyness of the cortical ribbon, not the nice large gyra that you'd expect to see. Maybe a little bit of polygyria or micropolygyria here. But the abnormalities are really pretty subtle on external examination of the hemispherectomy. In practice, we very rarely get an anatomical hemispherectomy like these days, because as you know, Dr. Mathern usually does a modified hemispherectomy, and very often the hemisphere comes out in multiple fragments, or he'll do a hemispherectomy where he leaves the occipital and the frontal lobes in situ to buttress the other cerebral hemisphere. But this was our first case. And this turned out to be a case of what we would now call Palmini type 2B cortical dysplasia with very, very widespread abnormalities, except we really didn't know what to call it in those days, and the Palmini classification only came out in the early 2000s. So we basically said that the pathology was really identical to what we would see in tuberous sclerosis, but the child had no other stigmata of tuberous sclerosis. So a pretty dramatic example. There have been a number of terms that have been used to describe cortical dysplasia. It was also described as cortical dysgenesis, and briefly known as synaptic dysgenesis. It's part of a group of abnormalities called neuronal migration disorders, sometimes also described as a malformation of cortical development, or an MCD, or a disorder of cortical development, or a cortical mantle formation. In a way, it's unfortunate that the term cortical dysplasia has remained the defining term for this entity, Because in general pathology, dysplasia always has an implication of it being a pre-malignant lesion. And there's not the slightest bit of evidence that cortical dysplasia is a pre-malignant lesion or that it behaves like a neoplasm, or that it behaves like a mass lesion for that matter. So it's a slight difficulty of terminology, but it is the term that has stuck in the most recent paper, position paper, defining neuropathologic categories of cortical dysplasia. In fact, has the term cortical dysplasia in the title, so I think it's going to be around for a while. Just a 2-minute tutorial to remind you of the cellular and molecular, the events that probably are important in the pathogenesis of cortical dysplasia. Remember that the cortical mantle forms by the migration of neurons from the germinal matrix, which is illustrated here, adjacent to the lateral ventricle, here adjacent to the temporal horn of the lateral ventricle. Those neuroblasts or neuronal precursors migrate out to the neocortex and along radial guide wires, and then there's a certain amount of migration of neurons horizontally in the cortex as well. So most of the neuronal precursors migrated out to the neocortex. It's probably complete by about mid-gestation, so by about 20 weeks, 22 weeks, most of the neuronal precursors have migrated out to the cortex. And remember, it happens in an inside-out fashion so that the deeper cortical layers are populated first, and then the more superficial cortical layers leapfrog over those. And that's thought to be an opportunity to make synaptic connections and so on. And really what happens in the later months of intrauterine life and the first few years of postnatal life, when babies are like really kind of spazzes, is that the cortical maturity is occurring because of apoptosis and pruning of synapses and so on. But the actual migration of the neuronal precursors is pretty well complete by about 4.5 or 5 months of intrauterine life. And you know as well, of course, that the germinal matrix wreaks havoc in prematures who are actually born with a relatively intact germinal matrix, or at least a residual germinal matrix, and can get hemorrhages into that, which then can extend into the cerebral parenchyma and lead to severe neurologic abnormalities. And I don't know if you ever operate on those children, probably not, but it's a big source of problems, germinal matrix hemorrhage. So again, to review, this is the ventricular zone, so the ventricle would be down about here. Again, the neuronal precursors really migrate. The proliferation occurs in the ventricular zone, and they migrate out to the neocortex and populate the cortex and produce that nice hexalaminar pattern that we recognize in older children and in adults. And you know I'm being very cavalier about discussing the complexity of this. There are very important influences of Cajal-Retzius cells in layer 1 of the cortex and various inductive influences and so on. And the radial glia have a very unique biology themselves. Many people feel that those radial glia can then actually turn into neurons or neuronal precursors as well. But there are people who can talk to you much more eloquently about that than I can. But it's a derangement in this process that probably contributes to cortical dysplasia, although exactly how we don't know. Both, probably both. I'll say a little bit more about that when I talk about the immunohistochemistry. This is an example of very severe cortical dysplasia. This happens to be a hemimegalencephaly in a young infant, contrasted with relatively normal cortex and white matter. It's maybe not an entirely fair comparison because I think the child that was operated on was only about 7 or 8 months of age, and certainly the centrum semiovalle wouldn't be fully myelinated by that stage. But it really is to show the contrast between the normal cortical ribbon and white matter and a hemimeg case where there's virtually no junction between the cortex, no visible distinction between the cortex and the white matter. There's just this big sort of gray soup, no secondary sulcal or gyral formation whatsoever, which there certainly should be by the age of 7 or 8 months. This is from that very first hemispherectomy specimen that I showed you externally, and it shows you how variable the pathology can be, because both of these specimens are from that case of the hemispherectomy, and it ranges from relatively normal cortical ribbon and normal cortex white matter junction to areas of very gross abnormality within the cortex, with a blurring of the cortex white matter junction, these rather large gyri, almost mushroom-shaped gyri, and very, very poorly delineated cortex white matter junction. And these were the areas where the cortical dysplasia was really by far the most severe. And occasionally we can see, not in that case, but we can see large heterotopias of gray matter in the deep subcortical white matter, even when the overlying cortical ribbon looks relatively normal, although in many areas the cortical ribbon does not look normal. And I mentioned to you that one of the helpful stains that we use is a Kluver-Barrera stain, which is a combined myelin stain and crescel violet stain, so it shows both cortical abnormalities and abnormalities of the subcortical white matter. And it shows really rather spectacularly a couple of things in this specimen. It shows you that there is broadening or widening of the cortical ribbon. This is from an older child of about 3 or 4 years of age, if I recall. Some blurring of the cortex white matter junction. And then you see there's almost a dual cortex or a double cortex here with large collections, what turned out to be large collections of neurons just beneath the original cortex. Not only that, but you see these large pale areas, which are areas devoid of myelin, and these areas actually had large collections of heterotopic collections of neurons in the subcortical white matter. So it suggests that these were neurons or neuronal precursors that were entrapped in the process of migration from the germinal matrix out to the cortex for reasons that are not entirely clear, and more subtle examples of heterotopic gray matter in the deep white matter here. So this is a very helpful stain to show the pathology really at a very low power. But of course we look at higher power. This is an example of relatively normal cortex. You might say, what happened to the nice hexalaminar arrangement of neurons in the cortex, because neocortex is a hexalaminar structure. And I would agree that it's pretty, the hexalaminar pattern is not obvious here. You can vaguely make out a layering pattern here. But that layering pattern, the hexalaminar pattern, really becomes much more prominent when you're looking at 100-micron thick sections that give you a sense of depth of the cortex as well. But remember that layer 1 of the cortex is relatively hypocellular, and then the more deeper layers are layers 2 through 6. And this is an example of severe cortical dysplasia photographed at an identical magnification to the control specimen, showing you crowding and tremendous disorganization of neurons, abundant neurons in layer 1 of the cortex, far more than you see in the control, and just very, very marked disorganization of the cerebral cortex. This is a higher power view from another specimen, showing again that neuronal disorganization, but now showing another abnormality, and that is abnormality of the neuronal polarity. So in fact, the peel surface is up here, but the apical dendrites of all of these neurons are directed towards the subcortical white matter. So tremendous loss of polarity. The other abnormality that you see here is neuronal crowding, and as well you see cytologic abnormalities in the neuronal cell bodies, and that the Nissl substance appears to be rather clumped. The nuclei are somewhat dysmorphic. And this is one of the defining features of what we used to call Palmini type 2A cortical dysplasia, which has now been redefined by the ILAE. You can occasionally see ectopic neurons in the subcortical white matter. So here you see oligodendroglial cells in the deep white matter, and then you see scattered neurons here. You can highlight the neurons in the subcortical white matter using a neurofilament antibody or a synaptophysin stain, but they're easy enough to see on H&E. This is just to show you some of the neuronal abnormalities at a higher magnification, showing again dysmorphic nuclei, very often of the poorly visualized nucleolus, and then clumping of the Nissl substance or rough endoplasmic reticulum, and then tremendous disorganization of the neuronal cell bodies. And notice some cells with a neuronal nucleus, characteristic nucleolated nucleus, have virtually no Nissl substance in them at all. So they really look like they almost have an astrocytic phenotype in terms of the cytoplasm, but a neuronal nucleus. And in fact, you can show that many of these cells have indeterminate phenotype between astrocytes and neurons. And again, Carlos has recorded from these cells showing that there are electrophysiological abnormalities in these cytomegalic neurons. He can actually culture some of these cells and measure action potentials and measure electrophysiological properties in the cytomegalic neurons directly, and then can study those morphologically. And there are tremendous cytoskeletal abnormalities. Not only is there an abnormality of the rough endoplasmic reticulum or the Nissl substance, but very often the cytoskeleton is very, very markedly abnormal in these neurons, so that you can actually use a silver stain, which you normally use to look for cytoskeletal abnormalities in Alzheimer's disease and Pick's disease and neurodegenerative disorders, and you could actually see these tremendous clumps of cytoplasmic material in the neuronal cell bodies. They almost look like inclusions in some cases. And then one of the defining features of severe cortical dysplasia, and what really suggests a linkage between severe cortical dysplasia and tuberous sclerosis, is the presence of these very bizarre balloon cells, which are cells with a glassy eosinophilic cytoplasm that look a little bit like gametocytic astrocytes. They very often have dysmorphic nuclei with internuclear inclusions, cells that have multiple nuclei or bilobed or trilobed nuclei. And these balloon cells are virtually identical to what you see in the tubers of tuberous sclerosis, and have some features of astrocytes, but also some features of neurons. And they are variably GFAP positive, so GFAP being an astrocytic marker. They can have subtle degrees of GFAP immunostaining, but some of them are not immunostained. And by contrast, reactive astrocytes are uniformly GFAP immunoreactive. And those balloon cells are electrophysiologically very quiet. So these are probably not a generator of seizures in a focus of cortical dysplasia, although their presence really tells us that we're dealing with an example of profound cortical dysplasia, and we usually see that in conjunction with neuronal cytomegaly and cytoskeletal abnormalities. So the profound abnormalities, the most profound abnormalities in cortical dysplasia are not only the neuronal disorganization and lack of layering and crowding of neurons, but cytoskeletal abnormalities in the remaining neuronal cell bodies, and then balloon cell change, which tell us that we're dealing with an example of severe cortical dysplasia, which is not subtle. And then Carlos Cepeda, again, injecting these neurons after doing electrophysiological recordings, can actually trace out the dendrites and the axons from these neurons, and is actually published on the various dendritic abnormalities that we see that presumably contribute to the epileptogenesis, although it's still the big question, what is epileptogenic about cortical dysplasia, even when it's quite severe. Carlos was the lead author, and Gary was the senior author on a paper that summarized a theory of cerebral development that leads to cortical dysplasia a few years ago. They can discuss it in much more detail than I can, but basically their thesis is, and was, I believe, that actually the abnormalities that occur in cortical dysplasia, although they may be related to events in early neuronal migration from the germinal matrix to the cortex, may actually reflect abnormalities of neuronal pruning and neuronal refinement as the cortex develops. So it may actually be, cortical dysplasia might actually be in large part an abnormality that occurs relatively late in development of the cerebral cortex. Although, again, there's really no good animal model of cortical dysplasia yet that would allow one to look at this. I'll just show one example of a severe case we encountered a few years ago that had extremely interesting pathology, and we've seen one other case subsequently like this. This was in a 4.5-year-old Hispanic boy who had, by neuroimaging, what looked like severe cortical dysplasia, and was operated on. And when he was operated on, he did have severe cortical dysplasia, but he had an overwhelming proliferation of Rosenthal fibers in the subpial region, in the cortex, and in the subcortical white matter, which is really quite unique in our experience of the hundreds of cortical dysplasia cases that we've seen. So we wondered whether he might not have an abnormality of, a genetic abnormality of the GFAP gene. Because are you aware of a neurodegenerative disorder that occurs in infants and children where there's an overwhelming proliferation of Rosenthal fibers? Very good, Alexander's disease. So we thought this might be kind of an example of a focal Alexander's disease or a form first of Alexander's disease. And we'd frozen tissue on the case, and we sent it to one of the GFAP gene labs, and they were not able to find any kind of a mutation in the case. This just shows some of the balloon cells in the Rosenthal fibers, so we tried to explain this in a number of different ways. We suggested that maybe the coincidence of cortical dysplasia and the overwhelming Rosenthal fiber pathology was just a coincidence. We thought initially there might be a GFAP mutation that impairs radial glial function with consequences for neuronal migration. But as I mentioned to you, we had the gene analyzed, the GFAP gene analyzed, and it was totally normal. And then maybe the most likely explanation is that the cortical dysplasia was producing upregulation of GFAP and/or protein accumulation to levels sufficient for Rosenthal fiber formation. And you might think there's nothing new under the sun, but we actually see what look like new entities all the time because of the large epilepsy surgery program. And this is an entity that was described by Cynthia Hawkins at Sick Children's Hospital in Toronto, which also has a large epilepsy surgery program. And they encounter these large, bizarre astrocytic inclusions in one of their cases, or one or two of their cases. And they kind of surveyed North America to see if anyone had seen anything similar to this. And when we opened this issue of the journal, we realized that a few weeks before we had seen a case virtually identical to this, with these abnormal serpentine kind of inclusions in the cortex, and sent the case to Sick Children's in Toronto, which showed that in fact this was a case of a filaminopathy. There's been a more detailed molecular analysis now of these filaminopathies, which suggests that there are very specific protein abnormalities that lead to the astrocytic inclusions that might actually contribute to the epilepsy. And so a paper's just been submitted describing that abnormality. Just a couple of the immunohistochemistries that are very helpful in further characterizing cortical dysplasia. Not that we do this on every case, but we do this on a selection of cases. This is an example with heterotopic gray matter in the subcortical white matter. So this is actually a ventricular lining, and you'll see nodular collections of disorganized neurons in the deep white matter. And these can really be highlighted using synaptophysin immunohistochemistry, which is a synaptic protein marker. In normal white matter, you should not see any synaptophysin immunoreactivity, but here with the nodular heterotopias in the subcortical white matter, they light up beautifully with the synaptophysin antibody. Neurofilament markers are very valuable for showing axonal and dendritic abnormalities and just cytoskeletal abnormalities in general in cortical dysplasia or non-cortical dysplasia lesions. And this is an example of a relatively normal neurofilament immunostaining, although with one neuron that seems to have abnormal dendrites. And this shows profound cytoskeletal abnormalities in another region with cortical dysplasia, in which you see abnormal dendritic arborization, abnormal cytoplasmic abnormalities. So the neurofilament immunohistochemistry is extremely valuable. And it can also show you abnormalities of neuronal polarity. So in this case, the PIA is somewhere up here. Subcortical white matter is somewhere down here. So for the most part, the apical dendrites are pointing, as they should, to the PIA. But there are a couple of weird neurons here with abnormal polarity. You can actually quantify that looking at large numbers of neurons. So the neurofilament immuno is quite valuable for this. This is actually a study that we did some years ago where we actually looked at co-expression of neuronal and astrocytic markers in an example of cortical dysplasia. It's about 9 or 10 years ago that we did the study. I kind of call this a poor man's confocal microscopy. This was done by a very good postdoctoral fellow in the laboratory. So these are actually 3 serial sections from a region of severe cortical dysplasia shown in panel A, B, and C. Panels A and B are stained with 2 different neurofilament antibodies, 2F11 and N52, one of which recognizes phosphorylated neurofilament epitopes, one of which recognizes non-phosphorylated epitopes. And then panel C is from a section stained parallel or serial section stained with an antibody to GFAP, showing you that in fact many of the cells express both neuronal epitopes and astrocytic epitopes. And some of them express only one of the neurofilament epitopes and an astrocytic epitope, whereas basically other cells will express neuronal or neurofilament epitopes but not express GFAP. So it seems like there are populations of cells in these areas of cortical dysplasia that are either dedifferentiated or have never differentiated along committed neuroglial lines towards either neuronal or astrocytic differentiation. So you can see that using either the serial section approach or confocal microscopy. So there's more to migration, the neuronal migration abnormalities than just abnormalities of neuronal migration, I guess would be one way to put it. There are very important abnormalities of neuronal differentiation and expression of neuronal versus astrocytic markers. So many of these foci of cortical dysplasia have individual cells that express both neuronal and astrocytic epitopes. Are they proliferative? I've mentioned to you several times that in general, cortical dysplasia does not behave as a mass lesion. And if you actually look at proliferating cell markers, which is Ki67, you will very, very rarely find a cell within a focus of cortical dysplasia that is immunoreactive, but the vast majority of the cells are not immunoreactive. This is a little bit different, of course, for many of the tumors that are that cause epilepsy, like DNETs and gangliogliomas, where there is a low but finite number of cells that usually are proliferating. Until a few months ago, we always signed out our cases giving, when there was a case of cortical dysplasia, giving it a Palmini grade. This is from a schema that was put out in around 2004, 2005, and really subtyped cortical dysplasia into type 1, which is a very subtle degree of cortical dysplasia, type 1A and 1B using subtle differences in the neuronal architecture and cytology. Type 2A and type 2B represented more profound abnormalities of the neuronal cytology and cytoskeletal abnormalities, whereas type 2B was really identical to the tubers of tuberous sclerosis, but in a child with no evidence of other stigmata of tuberous sclerosis complex. I wouldn't spend too much time worrying about this because this has really been modified now in a new International League Against Epilepsy scheme for classifying cortical dysplasia that builds on the Palmini grading scheme, right? So it doesn't totally discard it, but it builds on it and identifies an additional types of cortical dysplasia based on neuronal organization or disorganization or cytologic abnormalities. And that's been published in Epilepsy, and it's the system that we use now. I'm sure Rich has been involved with the sign out of some cortical dysplasia cases where we look at abnormalities that are characteristic of different ILAE grades of cortical dysplasia. Let me just say a couple of words, I know we're getting near the end of the hour, about the relationship between cortical dysplasia and tuberous sclerosis complex. So one important message to take home is that severe, what we used to call Palmini type 2B cortical dysplasia is really not differentiatable from a tuber of tuberous sclerosis without additional genetic and clinical information. They can be virtually identical, and you really can't tell the difference between them, although there are sort of subtle qualitative differences between a tuber of tuberous sclerosis and a focus of cortical dysplasia. And you know that tuberous sclerosis is a systemic disorder, and there are major and minor diagnostic criteria for tuberous sclerosis. But certainly the presence of cortical tubers or subependymal giant cell astrocytoma, or what's now called subependymal giant cell tumor, are major diagnostic criteria for TSC, tuberous sclerosis complex. The genetics of these disorders really took off in the 1990s when the gene for TSC2 on chromosome 16p was cloned, and it encodes a protein called tuberin, for which you can make very good antibodies and label neurons and other cells that show expression of tuberin. And then about 5 years later, the TSC1 gene on chromosome 9 was cloned, and it encodes a protein called hamertin. And both of these molecules seem to have some properties of growth suppressors, so that the genes are thought to be growth suppressor genes. Now you know that this is from I should put the credit line in here, this is from a very nice review article on tuberous sclerosis complex from the NEJM, from Kreino and Elizabeth Hensky from about 2 or 3 years ago. It really shows that the TSC1 and the TSC2 genes and the gene products are really extraordinarily important in many cellular functions, I guess is the bottom line of this slide, including molecules that have to do with cell proliferation, CDK1 and cyclins, GSK3 beta. It's got tremendous influences. TSC1 and TSC2 gene products have tremendous influences on insulin signaling pathways and mTOR pathways, which are just beginning to be explored. And this has actually led to a medical therapy for subependymal giant cell astrocytoma, which is to actually give a drug that influences the TSC1 and TSC2 effects on the insulin signaling pathway. And you can actually give the medication to make subependymal giant cell tumors shrink with this drug by interfering with a molecular pathway that leads to activation of the insulin signaling pathway. Very, very important and very pivotal role in many cellular functions. We can talk about those at another time.